Yeah, so I mean, explaining urodynamics to patients is definitely something that I think is a bit of an art. So I do like to show them the tracing and sort of explain to them that it's a pressure reading. And usually I like to use terms like this is where your bladder is squeezing harder than it should be, or squeezing when it's not meant to be squeezing. And I explain to them that's usually a consequence of changes to the nerves as a result of the multiple sclerosis. And in this situation, when I showed him that, I mean, I think that really replicated, the study really replicated his symptoms. So I like to sort of confirm, when this happened during the urodynamics, is this what happens at home? Is this what you feel at home? And in this case, he said, yes, that's the same thing that happens. I have that feeling in my bladder. I leak urine just like he did during the test. And that all sort of fits together nicely. And I think it's good for them to sort of see that objective evidence of their symptoms. And then from there, I will sometimes do a repeat study on them after treatment to see if things have improved. And then you can really put them side by side and show the patient the difference. That being said, if he responds really well to treatment and is doing well with significant symptom resolution, oftentimes I won't repeat the urodynamics in a patient with MS if I'm pretty happy that we addressed the problem fully.
Can you use the urodynamics to make the patient, let's say, more compliant, or let's say and makes the patient better understand your treatment plans for him? You mentioned that sometimes it's not easy with getting a patient on intermittent self-cauterization, but can you use the urodynamic trace to explain, listen, that is wrong and that's why you need it, so he can better comprehend why he's doing a certain therapy?
I think so. So a lot of times in people when I do a voiding phase and they've got detrusor underactivity or an acontractile detrusor, I'll show them the pressure line and say, your bladder is static. Your bladder is not moving. It's not squeezing like it's meant to be when you're voiding. And that's why you need some extra help to empty the bladder. Or with video urodynamics, you can show them the EMG reading sometime and really show them where the sphincter is not relaxing and really sort of put a picture to their detrusor sphincter dyssynergia. And I think providing them with some of that evidence and providing them with a diagnosis really helps sometimes move along their therapy and get them to consider sort of the next step, whether it be starting intermittent catheterization or, making the leap up to tertiary therapies and considering a trial of intravesical Botox or, for some conditions, neuromodulation.
Yeah, I have the same experience, and I agree. It's the more people can also read in the internet, they really want to understand what's going on, and I think it's their right to be informed and that you well explain to them what's going on with their body and why you proceed with a certain treatment.